This topic is very small, but it has got a very big surgical importance. And this mastoid is a part of the temporal bone which lies laterally. So this is your ear turned that side, and this will be your mastoid. So it is in the postoral region. It's a part of the temporal bone, and inferiorly there is a projection called mastoid process. And this mastoid process is absent at birth. This is mastoid process, and it is absent. Mastoid process is absent at birth. It starts developing by 2 years of age, and it reaches adult size by puberty, that is by 18 years. So in infants, here comes your stylomastoid foramen, and the facial nerve comes through this part and emerges through the stylomastoid foramen. So if the mastoid process is absent, the facial nerve may exit directly in the postoral region. So if you you know that this is the postoral William Wild's incision. William Wild incision. Postoral incision we put from the highest attachment of the pinna up to the mastoid process. And if there is no mastoid process in infant, if you put a usual postoral incision, there is a chance that you may injure the facial nerve. So in infant, this incision is put more often horizontally. That is one thing you have to remember. In infants, the postoral incision is put more horizontally than in adult, because there is no mastoid process and the facial nerve can emerge directly from the stylomastoid foramen, and in order to avoid injury we put a more horizontal incision. And another important thing is that this mastoid pneumatizes from two group of air cell, the superficial squamous cell and deep petrocell. So this petrosquamous lamina, petrocell and squamous cell. So this petrosquamous lamina, or otherwise called the corner septum, cornus septum. So this corner septum will be present on the deeper to the mastoid antrum, and it can be misdiagnosed as the medial boundary of the mastoid antrum. And if the actual disease may lie deeper to the corner septum. So if we stop drilling there, the surgery will be incomplete, as the deeper air cell or diseased cells will lie deep to that. So identification of corner septum during surgery is very important for complete removal of the disease. And only the mastoid process is absent at birth. This mastoid antrum is present at birth. So all the structures of the ear are present or formed at birth except the external auditory canal and the mastoid process. So mastoid process and external auditory canal, they are absent at not fully formed at birth, and all other structures are fully formed at birth. It's not, external auditory canal is not absent, mind you, it is not fully formed at birth. So all structures, it can be asked as MCQs. All structures of the ear are fully formed at birth except mastoid process and external auditory canal, and three structures are of adult size at birth. They are the middle ear, inner ear and the ossicle. So middle ear, inner ear and ossicles are of adult size at birth. So this is the styloid process. This is the lateral wall. This is a temporal bone. This thing, styloid process. Internal jugular vein and internal carotid artery. This is your mastoid process. This is zygoma, and this is the root of zygoma. And this will be the mastoid bone. So after drilling you can see that. And this is your external auditory canal. So I can draw the middle ear. What you see here? You see the medial wall of middle ear directly, and this is a facial nerve. So if I draw here, up to this will be your medial wall. Okay, so this is the lateral semicircular canal, and this is your facial nerve. This will be the anterior wall. The eustachian tubes go from the anterior wall, and your promontory, oval window, round window, and this is the posterior wall. Okay, and almost here comes the additus. Through the additus, middle ear communicate with the mastoid antrum. So this is the mastoid antrum. Mastoid antrum is an air containing space with a height of mastoid antrum. Then height of around 9 millimeters and a width of around 14 millimeters and a depth of 7 millimeters. Okay, and this is a mastoid antrum, and this mastoid antrum is a constant feature. It is the most largest air cell and is constantly seen. And remember, mastoid antrum is present at birth, but mastoid process is absent at birth. And the boundaries of the mastoid antrum are important. Boundaries. So the roof is formed by the tegment plate. Roof. This is the middle ear part. Here comes the tegmen, tympani, and this is the tegmen, antrum, tegment plate, and this separates the mastoid antrum from the middle cranial fossa, temporal lobe. So next is medial wall. Medial wall is this wall is the medial wall. So medially, this formed by the petrous part of temporal bone, and you can see the following structures. This is the lateral semicircular canal, and this one is the posterior semicircular canal. This is the posterior semicircular canal, right? So in the medial wall, we can see the posterior semicircular canal, and below this is the endolymphatic sac, and also there is dura of the posterior cranial fossa. So there you can see the posterior semicircular canal, endolymphatic sac, and dura of the posterior cranial fossa, right? So roofi, lateral and medial. Then anteriorly, anterior boundary. It's very clear here. See, this is the anterior wall. Anterior wall, through the in the anterior wall there is additus, and through the additus mastoid communicate with the middle ear. So from medial to lateral, the structures are, the first one, this is the facial nerve. Here will be the additus coming. So this is the facial nerve. Then comes the additus antrum, and then there will be the deep external auditory canal. So anterior wall formed from medial to lateral. Here the facial nerve, then additus antrum, and then the bony external auditory canal. So that is the anterior wall. So the roof, then the lateral wall, medial wall, and the anterior wall. Then what is in the posterior wall? It's very clear here. It is a sigmoid sinus. posteriorly comes the sinus plate. We separate the mastoid antrum from the sigmoid sinus. And next, floor. This is the floor. This is formed by the mastoid bone and the communicating aircells. From medial to lateral, it is the jugular bulb, then the digastric, posterior belly of digastric, and your sternomastoid muscle. So, in the floor, from medial to lateral, they are the jugular bulb, posterior belly of digastric, and sternocleidomastoid. So these are the boundary, roofed by the tegment plate. Laterally there is a squamous plate of temporal bone and the McEwen's triangle. Medially it is the posterior semicircular canal, endolymphatic sac and the dura of the posterior cranial fossa. Anteriorly comes the facial canal, adductus antrum and the bony external auditory canal. Posteriorly it is a sinus plate and the floor is formed by the jugular bulb, posterior belly of digastric, origin of posterior belly of digastric and the origin of sternocleidomastoid. So depending on the development, 3 types of mastoid aircells are seen. Types of mastoid. Cellular, that is, they are well pneumatized mastoid. There are so many aircells separated by thin intervening septum. And second is diploic. That is partly cellular and partly acellular. That is more of marrow spaces and less of cells. And third is sclerotic or acellular. There is no air cells, neither marrow spaces. In this case, this antrum will be very small and this sigmoid sinus will be anteriorly placed. So you should be careful while doing a mastoidectomy. And in normal population, this is seen 80% of cases. And this is 10% and again this is 10%. And this distribution varies depending on the nutrition, the eustachian tube function, hereditary and presence of repeated infections. So, and for the postgraduates, there are 5 regions of pneumatization of the temporal bone. One is the medullary region, then the mastoid region, perilabyrinthine region, petrous apex region and accessory region. There are 5 regions. One is medullary, mastoid, perilabyrinthine, petrous apex region and accessory region. Okay. So of the medullary region again divided into epitympanum, mesotympanum, hypotympanum, protympanum and posterior tympanum. And this mastoid region divided into mastoid antrum, central mastoid and peripheral mastoid. And perilabyrinthine divided into supralabyrinthine and infralabyrinthine. And the petrous apex region includes tubal region and petrous apical region, apex of petrosa. So tubal as well as the apical cells region is included under the petrous apex region, and in the accessory comes squamous cell, then zygomatic, occipital, and styloid. Okay, this is according to the regions of pneumatization of the temporal bone. It is divided into 5 regions: middle ear, mastoid, perilabyrinthine, petrous apex, and accessory. And all regions are again subdivided. In some cases, like example, after a translabyrinthine vestibular schwannoma operation, you have noticed troublesome CSF leakage even after obliteration of the tympanomastoid area, tympanomastoid cavity obliteration. This is because of the presence of various aircell tracts in the temporal bone. There are 5 recognized aircell tracts. One is postero-superior. That runs between the posterior and the middle cranial fossa area. Second is parallel to the postero-superior but inferior to that. That is posteromedial. Third is subarcuate. It passes through the arch of the superior semicircular canal, subarcuate, superior semicircular canal. And the perilabyrinthine runs superior and inferior to the bony labyrinth. Okay. Peritubal, around the eustachian tubal area. So these are the recognized aircell tracts. Postero-superior between the posterior and the middle cranial fossa. Posteromedial parallel to postero-superior but inferior to that. Subarcuate, it passes through the arch of superior semicircular canal. Perilabyrinthine, superior and inferior to the bony labyrinth, and peritubal. Some named spaces, triangles, angles and lines in relation to the mastoid region. One triangle. One is, I already discussed, that is a McEwen's triangle. That is already discussed, isn't it? That is on the lateral surface. Boundaries are discussed. Second one is a Trotman's triangle. Trotman's triangle bounded superiorly, anteriorly by the bony labyrinth. This is the anterior, posterior and superior. So anteriorly by the bony labyrinth, posteriorly by the sigmoid sinus here. And superiorly by the superior petrosal sinus. It comes almost here. Here will be the Trotman's triangle, and superiorly by the superior petrosal sinus. So actually this is a this area is a vascular cancellous bone, this part. So Trotman's triangle area is that bone is highly vascular and cancellous. So the osteitis or infections of this bone can lead to development of sigmoid sinus thrombosis or brain abscess. So that is the importance of this Trotman's triangle, bounded anteriorly by the bony labyrinth, posteriorly by the sigmoid sinus and superiorly by the superior petrosal sinus. The angles present related to mastoid are, one is Sittelis angle or the sinodural angle. It will come here, this part, between the sinus plate and the tegmen plate, sinodural angle. And the importance is that this is the site, commonest site of a residual cholecytoma. If you are not particularly looking to that and clearing the aircells, there is chance of the presence of a cholecytoma persisting there and presenting as a residual cholecytoma. And the solid angle is part of the bony labyrinth between the three semicircular canals. It comes around here, part of bony labyrinth between the three semicircular canals. And there is a line called Donaldson line. Donaldson line is a surgical landmark or surface landmark for the endolymphatic sac. Actually, this is the lateral semicircular canal. This line passes through the lateral semicircular canal, bisecting the posterior semicircular canal. Passes through the lateral semicircular canal, bisecting the posterior semicircular canal, and this endolymphatic sac is seen as a thickening on the posterior fossa dura. And this is the endolymphatic sac, this part. So this endolymphatic sac will be lying, or almost all the cases it is lying inferior to the Donaldson line. That is it. So you have to remember the names of all these: McEwen's and Trotman's triangle, Sitterly and solid angle, and Donaldson line. The next is on mastoid aircell. There are so many groups of mastoid aircell, and the different textbooks says different names. But mastoid antrum is most constant aircell and is the largest one. And at least you study 9 groups. Altogether we can tell it as 10 groups, including the mastoid antrum. And apart from mastoid antrum, study at least 9 group of aircells. They are, this is zygomatic, around the root of zygoma. Then peritubal, around eustachian tube opening. Then in the tegmen plate there are tegmen cells. Then perisinus, around the sigmoid sinus. Then there are tip cells towards the tip of mastoid. Then perilabyrinth, around the bony labyrinth. Then retrofacial, deep to facial nerve. Marginal. They are behind the sigmoid sinus, extending into the occipital bone. And also there are squamosal. Okay, so at least remember that zygomatic around the root of zygoma, peritubal around the eustachian tube area, tegmen in the tegmen plate, perisinus, perilabyrinthine, retrofacial. Remember each anatomy and think about remember the name of the aircell. Tip cell and marginal, that is deep to the sigmoid sinus going towards the occipital, and squamosal. At least remember these names. So along with mastoid antrum, we have discussed that mastoid bone, mastoid process. It's absent at birth and it is start developing by 2 years of age, reaching adult size by puberty. So that is the importance of the post-oral incision. Go for an horizontal incision in infants. Then we talked about the different types of aircells, then different types of pneumatization, aircell tracts, then the types of aircell, mastoid cells, the names of mastoid cell, then what the types of mastoid, that is the cellular, diploic and sclerotic, then triangles, angles and lines in relation to the mastoid, and also remember the boundaries of the mastoid antrum.